Hey everyone, Khalid here. Welcome back to Clinical Physio. Thank you so much for joining us for another case study. This patient has shoulder pain. If you like learning from case studies, please be sure to smash that like button. And otherwise, let's dive in with today's case. So we have an 87-year-old female patient who is presenting to us with right shoulder pain. We can see that the shoulder pain started 2 weeks ago after this patient had a fall and landed on her right shoulder itself. Now, she didn't have any shoulder problems before this fall. And since the fall, she's had a clear loss of function and increase in pain. And the key thing to say is that the pain and loss of function started immediately after the fall. It didn't come the next day, a few days later. Absolutely straight away, she started experiencing these symptoms. She isn't experiencing any paresthesia, any pins and needles or numbness in her arm. It's also important to say she's not experiencing any neck pain, and she doesn't have any significant past medical history other than some increased blood pressure for which she's taking Ramipril. Overall, a fit and healthy lady who's experiencing this shoulder pain. So next, let's look at her objective assessment. So when we start with observation, she's walking with no major concerns, no loss of balance or anything like that, which is important when we're thinking about cervical spine pathologies in case there's some incidence of myelopathy, but that's not the case here. What we can definitely see is that when she tries to lift her arm, she's actually hitching from the scapula. So rather than doing this, she's doing a little bit more of this when she's trying to lift her arm. When we look at her range of movement, there's a clear difference actively between the right and the left shoulders. With her left shoulder, she's got full pain-free range of movement. When we look at her right shoulder, it's significantly limited. 30 degrees flexion, 30 degrees abduction, only 10 degrees external rotation. However, it appears that she has quite good range of movement passively. We can see that she has 140 degrees of passive flexion on both the right and the left shoulders. When we look at her resisted tests, we can also see a clear difference between the right and the left sides. On her right shoulder, she only presents with 2 out of 5 strength on the Oxford scale between 0 and 5 for both shoulder abduction and external rotation. So 2 out of 5 meaning that she's unable to lift against gravity. Whereas on the left side, she has pretty good strength for someone of her age. And we go through some special tests specifically for the right shoulder. So we have a positive drop arm test. We have a positive external rotation lag test. We have a negative belly press test, however. So that's the subjective and objective history. Now it's over to you to think about what you think is going on with this case. What do you think is the diagnosis and why do you think that's the case? Pause the video, write down your thoughts and join us in a second. Okay, everyone, time's up. Let's go through the answer. So this patient had a fairly classical presentation for this diagnosis. If you have been following this case and you're wondering what's going on, the diagnosis of a rotator cuff tear should be screaming out at you. Let's go through why. As I said, this is a pretty classical case. So first of all, the first key point, before we look at anything else on the screen here, the patient's age. We know that when patients are in their older years, their rotator cuff tendons are far more vulnerable to injury. They lose strength over time, they start to fray a little bit, and they're far less resilient to if a 37-year-old patient had a fall and landed on their right shoulder. So automatically, when we think about that age group involving a trauma, we should be thinking about a fairly significant injury as a possible outcome. So indeed, for this patient, because they've had a direct trauma where they have fallen directly onto their shoulder, we automatically need to think about the fact that they could have a significant injury like a rotator cuff tear. Now, we also have a fairly consistent difference here between active range of movement and passive range of movement. And you should all be thinking that when we have patients with a small amount of active range of movement significantly affected, but passive range of movement is relatively well maintained, that gives us a relatively clear indication that there is an issue to do with the contractile structures moving that joint. So therefore, we're thinking about muscle, tendon, or nerve, because those are the contractile structures that make up the contractile pathways. And the fact that she's got very good passive range of movement suggests to us that there is no clear joint issue, and it's probably unlikely that she has a fracture, because we would expect passive range of movement to be significantly affected with a fracture. So therefore, that difference between active and passive is key. Please do note, not every patient with a rotator cuff tear will have that clear difference. Some will present with relatively restricted passive range of movement as well, because of pain levels. However, when we do see that difference, it gives us another clear indication that we should be thinking about active contractile structures rather than joint structures. Then we see about the strength. We can see that the resisted tests are significantly limited for this patient, only 2 out of 5 on the Oxford scale, and we have positive special tests which are linked to rotator cuff tears, that being the positive external rotation lag sign and the drop arm test. Now, we had a negative belly press test. The belly press test is looking at subscapularis, because the belly press test is for medial rotation, checking the strength there. That was negative, so it kind of gives us the impression that subscapularis possibly is intact, but the fact that her external rotation is affected and drop arm is affected probably makes me think about supraspinatus plus possibly infraspinatus as well. Naturally, this patient might have some investigations, perhaps something like an ultrasound scan to confirm the diagnosis. And speaking about investigations, whilst, as we said, this patient has good passive range of movement, so a fracture is probably unlikely, they should absolutely be having an X-ray just to be sure. X-rays are simple, cheap investigations that can tell us so much. So we would definitely want to make sure that this patient has had an X-ray if they haven't had one already, just to rule out the possibility of a fracture, because that will have a major impact on her management. So what do we do with this patient? Well, as I said, we'd probably consider referring them for a further investigation, such as an ultrasound scan, to confirm the diagnosis. Some of these patients will have surgery, some of them won't. Given the patient's age, it would be often reasonable to try physiotherapy in the first instance to try and see if we can improve range of movement. What kind of exercises? Well, we'd be probably looking first of all at exercises that are part of the anterior deltoid strengthening program. You can look this up online. Anterior deltoid is a really well used set of exercises for patients with rotator cuff tears. Here are a couple of examples on the screen of exercises that you might use to try and improve their flexion. And it will take a long time for that rehab to be effective, but if it can prevent surgery, then it's a great option for patients. So everyone, I really hope you've enjoyed this case study. If you have, please support us by smashing that like button. It's the #1 way that you can help our channel grow. Remember, if you want more resources from us, we have our Instagram account at Clinical Physio, and we're also on TikTok at clinical.physio if you'd like to follow us on social media. And if you like learning from case studies, please do check out our membership platform, link in the description below, member.clinicalphysio.com. There we have the Case Study Club, in which we have expert physiotherapists coming on to describe case studies to help you learn. And of course, we've got brilliant tutorials and webinars associated with those injuries as well, which you can all find at member.clinicalphysio.com. My name's Khalid. Thank you so much for watching. See you soon here on Clinical Physio.